Good afternoon, everyone. My name is Peter Gaitis, and I'm the Executive Director of New York Disaster Interfaith Services. And welcome to our webinar on the new mental health toolkit for the COVID-19 pandemic. This webinar is specifically on grief and trauma. The webinar is being co-sponsored and co-written by the Interfaith Center of New York, represented on our webinar today by Dr. Henry Goldschmidt, and the Office of Thrive NYC, which is the Mayor's Office for Mental Health Advocacy and Support. This toolkit includes a portion of information that is what's called evergreen. So it is general information about mental health wellness for faith and community leaders. And there is a section within the toolkit that is specific to the COVID-19 pandemic. We also want to name the fact that while we are faced by the challenge of COVID-19, we are also facing a resurgence of interest and passion and anger and upset for racial inequality and inequities in the United States, pioneered at the moment, led by the Black Lives Matter movement. And as we look at the pandemic of racism, which is now centuries long in the United States, as well as the COVID-19 pandemic, we also have to tilt our eye towards the inequities in access to care and treatment and fatalities. So the majority of infections and fatalities here in New York City have been in the African American and Latino communities, including their religious leaders. So that is another dynamic to our conversation today. So I'd like to introduce our speakers for the day, the Reverend Dr. Storm Swain, who along with Father Stephen Harding wrote the pandemic content of this toolkit with some contributions from a few others of us. And then our panel discussion today is going to be moderated by Father Harding with our panelists Ali Geith, who is, has a long time association with NITIS, going back to 9/11, and he's going to introduce himself later in the webinar, and Mary Reagan, who also has a long association with me, as well as NITIS, and they will introduce themselves at the beginning of the panel later. But first, we have a very short video from the Mayor's Office of Thrive NYC, and then Dr. Swain will give us our toolkit workshop. So thank you for joining us. Are we having a glitch?
Can't hear the sound there, Holly.
I apologize. Let's see if this works. Is it audible?
No. No.
No.
Make sure the box in the bottom left is clicked in the video.
Mm-hmm.
Books. Is it muted on the video? Is that what you're asking, Ali?
No, it's not.
No, there's a box in the, when you show a video in the bottom left, it has to be checked for the sound to come out. Yeah, this goes back to the setting.
Yeah, this is in the share screen piece. When you share your screen in the lower left, there are 2 buttons that you have to check.
Our apologies, everyone. With computer sharing, this has become an issue, but normally it works fine.
It happens.
Holly, do you want us?
It's me who's sharing it, Helena. I'm sorry, I'm not seeing the boxes to be checked on the bottom left of my screen.
Helena, do you want to start sharing and I'll see if I can bring it up?
Sure.
Okay, I can do it as mine worked in the past. All right, guys, just hold on 1 second. We are gonna get the video up. Thank you for everybody's patience. Share screen.
All right, let's skip the video and move on. Unless you can get to work right now.
All right.
This looks very pixelated.
I think we'll move on because there's no
Yes, let's
play
move on.
button in the middle. So I am going to.
We'll just cut this out of the recording.
Well, that would have been a lovely welcome from Thrive to commend the toolkit to you and to welcome you to the webinar. So our intention is that this webinar is a fairly tight 1 hour. Part of it is we're going to have a presentation on the toolkit, which I will pick up, and then the Reverend Stephen Harding is going to facilitate a discussion with our panelists, and we should have time for a Q&A session. We will ask you to put questions in chat as we go through. So our objective is to introduce the toolkit to you, but pick up just 4 important things from it, in particular looking at grief and trauma today. If you haven't had time to go through the toolkit, I commend it to you afterwards to spend time and to think about it as a resource for those in leadership in your community and with some good access to resources. So we all have our timelines of what the COVID-19 pandemic has been for us. I can trace the life cycle of this disaster for myself from my Facebook posts. In January, when the news started to note the outbreak of a novel coronavirus in the Wuhan province, I was primarily posting about the Australian bushfires, Meghan and Harry deciding to step down as public royals, the climate crisis, Elizabeth Warren, and a rant about racism implicit in hospital admitting questions. January the 23rd was my first post about the coronavirus, with the news of the first case in the US. A month later, I posted about COVID-19. We had a name for it by then, and I had gone out and bought a liturgical dispenser for hand sanitizer for our church, and I was pleased to have found the last remaining 500 ml bottle of Purell on the shelves, even at that stage. On March the 10th, the seminary where I teach decided in abundance of caution that the March intensives that were supposed to be residential courses would become online. And that for me was the start of the response to the event that was beginning to impact the whole country. So I'm sure we all have these kind of stories to tell. and to think about what the life cycle of a disaster is for us. One of the key things to note for us as religious leaders is that we are in a disaster, and in such circumstances, care of community and congregation shifts from that of ordinary time to a crisis response. I think it's often helpful to have a general map of where we are in a disaster, conscious that this may shape our approaches and interventions for our faith communities. And I can easily trace my consciousness from that in January, where I was focused on mitigation, hygiene, to that in the February post of preparation, to that of mid-March, where the outbreak of the virus had changed the ways that we normally did things. All of a sudden, I went from in-person teaching to spending a whole week online in a Zoom class. And as is often characteristic of the early stages of a disaster, it felt like a heroic response on behalf of the class, where the students bought in and put up with this quick turnaround. We did it because we needed to, and those involved had a good buy-in to keep others safe. The first noted case in New York was on March the 1st. And on March the 7th, Governor Cuomo declared a state of emergency with 89 cases in the state. A week later, we saw the first 2 fatalities, and by March the 12th, public gatherings for over 500 were banned. So mental health during a pandemic or during a disaster is different from mental health during ordinary time. Well before we think about working through grief that we saw in that emotional timeline of the disaster that looks a little bit like a heartbeat, most of us are experiencing increased stress, decreased access to resources, and all of the pre-existing realities are true, with additional concerns laid on top as this viral pandemic, where we have been social distancing or quarantining, not participating in public gatherings and in-person worship, as it has felt unsafe to even step outside the door. The reality is, of course, that it has been unsafe for many of us to step outside the door even before the pandemic. And we are living with the consciousness that we are experiencing 2 pandemics, that of COVID-19 and of the pandemic of racism and racialized violence that has repeated waves of impact, most recently with the deaths of Ahmaud Arbery, Breonna Taylor, George Floyd, and others, and not to forget the experience of Christian Cooper in our own backyard in Central Park. So if we look at the layers of one pandemic on another, if this graphic is visually disturbing and hard to read, it gives a good picture of the internal experience of pandemic response overlaid with the pre-existing and ongoing reality of racialized violence and our response to it. And I think we could easily debate this for the rest of the morning, the rest of the afternoon. But I would suggest that both of these realities, with their repeated cycles of impact, are now being experienced as public health emergency at the least. And a community cohesion is appearing around the protests that I think is a positive response to this becoming a communal issue. If we go to, coming back to the toolkit, we can see that in the pandemic, someone has a good reason to be stressed. Living in New York during these last 3 months has been extraordinarily stressful. Generally, the feelings, as you see on the screen, are different than experiencing clinical depression or another mental health disorder that may require further intervention by a professional. These are normal responses to a stressful circumstance. And in most cases, empathic listening, pastoral care, education about normal stress reactions will help mitigate stress and anxiety. But you should also be alert for signs of profound psychological distress and for indicators that referral to a mental health provider is needed. On page 30 of the toolkit, there is a list of cognitive, emotional, physical, behavioral, and physical signs of stress that are common in a disaster. And in our faith communities, in a time of disaster where it is a common reality to be stressed, we need to look at three specific things to see when someone has moved from what we used to call a normal response to an abnormal event to having perhaps a mental health challenge or crisis. And these three things are time, symptoms, and impact. So you see in the toolkit, generally one should be concerned about a mental health challenge rather than a healthy response to highly stressful circumstances if and when a person alludes to wanting to die or talks openly of suicide, when a person seems to be isolated and withdrawn beyond what is required by social distancing, perhaps when a person presents imaginary ideas or details of persecution, when a person does not seem to know who they are, when they are, or where they are, when you become aware of an over-reliance on alcohol or drugs, perhaps see a person engaging in significant behavior that puts themselves or others in danger, or when you realize the problem is beyond your capacity of level of training to address. So we see particularly acute stress when these symptoms of stress are magnified, they go on for most of the time, they experience for most of the day, and they begin to affect a person's ability to care for themselves. Further to my timeline of mitigation, preparation, and response, for me it felt like the disaster really impacted 7 days after that online teaching intensive I spoke of. The following Friday, one of my friends and colleagues from Union Theological Seminary, a New Yorker, musician, minister, and psychotherapist, posted this on Facebook. My doctor said, just get through this weekend. Since then, we have seen a roller coaster of physical symptoms, paralleled by the anxiety, fear, sadness, and frustration engendered by a virus that has killed over 30,000 people in New York State alone. So you can see here perhaps the difference between anticipatory grief, preparatory grief, and the acute grief, the shock of hearing that one's life may be in danger. So just as with mental health, the reality of grief in a pandemic gets complexified. Most of the time, I think we take for granted what William Worden would call the first task of grieving, simply accepting the reality of a loss. In a pandemic where we are grieving the loss of routine, the loss of rituals of life, social contact, disconnection from jobs, transport, safe touch, the ability to gather and mourn with friends and family, grief becomes highly complex. For many whose death, who find death from the virus of family members, loved ones, colleagues, parishioners, congregants, members of your faith community was sudden, for those who are experiencing death of a loved one that they were not able to see and be present with, to gather at the bedside, perhaps having to say goodbye through the medium of an iPad held by a healthcare worker enshrouded in personal protective equipment. this person may well know the reality that their loved one has died, but feelings get put on hold, waiting for the usual rituals of grief to mourn in community and to move towards making those changes that might be equally impossible given the pandemic, to adjust to a world without the deceased. Therefore, I think as faith community leaders, we may anticipate a variety of expressions of complicated grief, as mourning may be delayed or extended, perhaps masked by other things, and the need to respond to a reality that does not look like at the moment that it's going to change significantly until there is a vaccine that is widely accessible and available to all aspects of society, to all persons, particularly those most marginalised from healthcare resources during ordinary time, including those who are most economically marginalised. My slide is not advancing. So within the toolkit, you can see some common tips for coping with grief and loss in a user-friendly way, and you can see that they follow good principles of grief counselling, helping survivors to actualize the loss, to identify and experience feelings, maybe anger, guilt, helplessness, anxiety, sadness that arises, and then thinking forward to assist living without deceased, finding meanings in the lost and ways to remember those that have died. As we think, however, about the possibilities of traumatic bereavement or trauma, however, as well as grief, we need to be aware that it is very hard to grieve if one does not attend to the trauma first. So let's return to my friend Heather for a moment. I said that she posted, "My doctor said just get through the weekend." What she didn't post, or later posted and then took down because it felt a little too exposing, and let me share that I have permission to share this with you, that she had to tell her 3-year-old and 6-year-old that she might not get through the weekend, but whatever happened, she loved them. Part of that traumatizing experience for her was that she couldn't hug them to comfort them as she was quarantining. And so her normal response to her children's distress felt like it was increased by her inability to reach out and touch at that time. So as we think about trauma in general, people are more likely to be traumatized when they are directly exposed to death and the threat of death, actual or serious injury to actual or threatened serious domestic or sexual violence, or seeing such violence happen in person to someone else. People can also be traumatized when they learn about a death or threatened death to a loved one that is accidental or violent, or I think particularly the kind of deaths that we are seeing in this pandemic. Traumatic stress starts to be considered if symptoms of acute stress continue over the following month and start to last more than 3 to 6 months after the event. A diagnosis of PTSD encompasses 4 clusters of symptoms that may perhaps be diagnosed 30 days after a traumatizing event. But part of the complexity of this pandemic is, when is this event over? When is the impact of this over? Or are we simply cycling through impact and response again and again and again? So as we think about the clusters of symptoms of hyperarousal, of avoidance, of re-experiencing, and those negative alterations in cognition and mood, we need to be alert to the impact of these on people's life, the duration over time, and the magnitude of these symptoms. So as thinking about the toolkit, we particularly want to think about when is it appropriate to refer, and to take account of that in terms of what you are seeing in members of your faith community. The toolkit gives some excellent resources, but doesn't leave you out of the picture either. As for others, so for ourselves, especially for faith community leaders in communities impacted by extensive outbreak of the virus, multiple deaths, incomplete safety standards, under-resourced populations, minority communities that are experiencing the ongoing realities of racialized violence, and in communities which speak languages not shared by the wider population. All of these are at significant risk of traumatic stress. So we need to know when we have reached our limit. My personal opinion is that with 9/11, the greatest risk to clergy and religious leaders responding to the disaster was PTSD. With COVID-19, I think the greatest risk is burnout. So all that you can do to retain a sense of agency, blessing, community, whilst following good safety protocols that affirm the agency, community, and create meaningful collaboration with others is a good way forward. So just to alert you to other things in the mental health toolkit, and particularly to how to refer to a mental health professional, and some good resources from NYC WELL with access to languages and a mobile crisis team that is available, and ways to connect through their website to find resources for your own community. So I am going to hand it over to Stephen Harding to pick up the discussion with our panelists, and thank you for your time and attention.
Thank you very much, Dr. Swain. If you could stop sharing your screen, that would be excellent. And I would like to welcome Dr. Mary Regan and Ali Geith. And I would like you, please, to introduce yourselves briefly, starting with you, Mary. And then if you could comment on anything that struck you about either Dr. Swain's presentation or the toolkit. Dr. Regan.
Thank you, Stephen. My name is Mary Regan, and I'm the Executive Director of the Psychotherapy and Spirituality Institute in New York City. We're a group of about 14 mental health clinicians who have an interest in the intersection of psychotherapy and spirituality. And we're located in 4 sites in Manhattan. Our main site is down at Trinity Church, Wall Street. We're at St. Bartholomew's, we're at St. John's in the Village, and Rutgers Presbyterian. So let me address the question that Stephen raises about what resonated with me in the toolkit. I think I'd like to begin just by saying that I found the toolkit fantastic, and really a remarkable resource for all of you who are dealing with congregants in this difficult time. So what I would like to focus on, and Stephen, you just let me know when you want me to stop, but what I picked out as the thing I would most want to focus on is this sentence in the toolkit. Complicated grief is like being in an ongoing heightened state of mourning that keeps one from learning to live with one's loss. So I live on First Avenue on the Upper East Side, and it has not been uncommon for me in the course of these weeks to hear hundreds of people marching down the avenue, chanting, "Say his name, George Floyd. Say her name, Breonna Taylor. Say his name, Trayvon Martin. Say her name, Deborah Danner." So why have the words "say his name, say her name" become the mantra of people who are marching in the streets? I think it's because without naming something, it cannot be dealt with. I was thinking about Betty Friedan's The Feminine Mystique, the problem that has no name. You know, if we can't name it, we can't deal with it. And because without naming an individual and a real person, statistics are sterile and they fail to convey what the human loss looks like. So complicated grief is like being in an ongoing heightened state of mourning. And that's what I think we're experiencing right now, an ongoing state of mourning. We don't even know the extent of our losses. We're in the beginning of the catastrophe, and we won't even know the full scope of what we have experienced until probably we are months into this, maybe years. So we know that grief is the death of something. And as Storm was noting in her presentation, this grief takes many forms. It can be the end of a marriage, the breakup of a relationship, massive unemployment, food insecurity, loss of our city as we've known it, the loss of rituals, graduations, school, bar and bat mitzvahs, the loss of small businesses which will never return. So I think that for me, in thinking about complicated grief, I'm thinking about the collective loss of the world as we knew it. We're not going back to that world. Whenever we come out of this thing that we're in right now, that world that we had won't exist anymore, and surely not in the way that we know it.
I'm going to say thank you. That
Yep.
seems like a good spot to transition to Ali Geith. If you could introduce yourself. Mary, we'll come back.
Oh,
Ali.
thank you very much, Brother Stephen. Thank you, Mary and Swan, for all the introduction, and thanks to NIDIS for the invitation. Like Peter mentioned earlier, I have been working with NIDIS for quite some time, trying to bridge understanding between formal mental health providers and spiritual and religious leaders. So I have been in the field of mental health for over 25 years now. And as was mentioned earlier in the introduction, I'm the director of a graduate program in emergency management at Metropolitan College, where mental health and spiritual care is one of the required courses that all future emergency managers would have to take and take very seriously, because we know the importance of mental health. And we know for a fact that in any common day that a lot of adult and young Americans experience mental health problems, specifically with anxiety and depression, and trauma is the #1 cause and lead to mental health problems, especially if it happened to a person at a young age, and a person can be easily traumatized. So we have dealt with pandemics before. We dealt with public health emergencies, and we planned for something similar to what we're dealing with right now, but we fell short of considering that this pandemic is not just going to be affected people worldwide and every state in the United States, because in previous public health emergencies, we were able to lean on one another. Now you see a lot of states are struggling to provide services to their own citizens, even though New Yorkers, we were fortunate that we have over 30,000 volunteers came to help us during the beginning of the pandemic of the COVID-19. So right now, yeah, we are doing much better because of a lot of the discipline that we have here in New York. New York, we're not immune, we're not strange to emergencies, disasters, if it's man-made or natural disasters. And one great thing about New York is how New Yorkers often come together and help each other to come out of any kind of crisis that we experience. So it is very important. I just heard about the introduction for the toolkit, which I believe is very, very informative, and it gives options. It gives the knowledge, but also at the same time, it gives some steps of what to do in case you experience mental health challenges. And it's very important because here, what also the toolkit is distinguishing between someone who's having a crisis of faith to someone who's having mental health crisis, which is extremely important. Always thought for faith communities to be able to distinguish what's the crisis of faith from what's mental health crisis, and how to connect someone to a professional mental health provider if they continue to feel that the pandemic or the crisis are interfering with their day-to-day life. So the toolkit sounds to me to be informative, and even it focuses on grief. And we know that grief is different for every person and every loss. The manner of the death or loss and your personal circumstances can affect how long you experience grief. And also, sorry, somebody's mowing the lawn next to me. If you are experiencing grief, and this is what the toolkit is introducing, it may be difficult for all of us to imagine an end to the pain we are feeling. Even though our life may not be the same as it was before, and that's what the toolkit is introducing, the grief will eventually ease. And the grief process will allow us to accept the loss and move forward with our life. However, like was mentioned in the toolkit, there are such things as complicated grief, where if, correct.
I'm sorry, can I just interrupt? Because
Sure.
both you and Mary are now mentioning complicated grief. And Mary read the sentence about being in a state of ongoing mourning that's not ending. But what does this actually look like? How would I, as a faith leader, see it and recognize it? What would I be looking for? And my question really is, how do you apply the knowledge, the data, the facts, the advice, the guidance in the toolkit? How do you take that and apply it to someone who presents to you or any of us as faith or community leaders? And
that's a very, yeah.
Going on.
This is a very good question. As a matter of fact, we all have to understand our own limitation to what can we do with someone. So earlier it was mentioned, if those reactions to crisis last for 4 weeks or more, it's important to connect with a professional provider. Now, for us as religious leaders, it's very important that we maintain that level of knowledge, knowing when a person feeling deeply angry about the death or loss, and this is lasting for a long time, being unable to think about anything but their loved one, not wanting any reminders of loved ones at all, having nightmares or intrusive thoughts, feeling deep loneliness and longing for a person they've lost, or feeling distrustful of others, and many others, such as feeling unable to maintain regular activities and to fulfill responsibilities, or feeling bitterness about life. So all these things we can see by the way we approach the person in a non-judgmental way and starting the conversation without shaming them or blaming them for the way they feel. Because again, everyone reacts to it differently. And it can be complicated for some people, especially in the current circumstances where it's not just risk to health, it's not just loss of jobs or being disconnected from a structure that I'm familiar with, or it's not, or maybe all of a sudden find myself at home with my kids that I need to homeschool and do all these things. Maybe I have lost someone. So this can make things really complicated. These are not normal times. And it is possible that nowadays, because of the amount of people that we have lost due to COVID, that you're going to find lots of people grieving about the loss. And specifically, as was mentioned earlier, the current circumstances where we want to give the ultimate respect to the dead person and give them the appropriate burial have been taken away because of the risk. So people are dying alone. Their families are not with them. And most circumstances, we have seen that people even unable to go to a funeral. So that created a lot of complicated grief where there's a sense of guilt. And,
Ali,
correct.
I'm sorry, I'm going to leave you there with the guilt. Thank you for your answers.
May I comment on that one, Stephen?
And I would like to come back to Mary before we go to question and answer. Please feel free to use the chat bar to ask questions.
Just a quick comment on that, Stephen. I really appreciate the comprehensive answer that Ali gave to that question. I have two things to say. One is, in a way, I think it's too soon in the pandemic for us to be identifying complicated grief because we are so early on in this moment. But secondly, I would say one of the things I work with the religious community who has a number of elderly members. They have recently lost 13 women, most to COVID, some not. And one of the things that we talked about and that they have executed is having a Zoom ritual rather than waiting. They were thinking that they would wait and later on memorialize all of these women. They started the Zoom rituals immediately, and they had 70 people on the Zoom. It was powerfully emotional, and people came from all over the country, who would not otherwise have been able to come to such a ritual. So I want to say, as a way of preventing some of, or as a mediator to some of the complicated grief, sooner rather than later to address the grief.
Thank you both. We have now come to the time for questions and answers. So I invite you to raise your hand or use the chat bar and ask a question. I see Peter Goditis' hand up.
I really appreciate everything that's been said so far. Something that I've discussed with some of you and other colleagues has been, you know, have we learned, the faith sector as a whole, to grieve differently and perhaps in a way that's more accessible than we have previously because of the pandemic. I mean, normally if you have a funeral, people come where they don't come, and people who live far distances away often aren't able to. But we now, I think, have gotten better in some ways at virtual opportunities to share in communal grief. And I'm wondering if that's going to change the way we grieve and make it more accessible. You know, will we consider, even once the pandemic is over, virtual opportunities for people to connect with rituals that normally they couldn't have? And the thing that I think I find exciting about that is I think it somehow equalizes access to these rituals that normally are only accessible by people of means. If you have to be wealthy in order to be able to travel to funerals. You also can't be somebody who works an hourly job where you're going to be told no, you can't, or feel like you're giving up income. So I'm wondering if there is, we always have to look for a little positive. If this offers us unique ways of grieving, and are those virtual ways of joining grieving communities as effective as participating in person? So I'm curious, Mary, about what you think about that.
Peter, I can tell you from this experience I had with this this one group that I'm talking about, is that they had a couple of different experiences. One was the level of emotional sharing they found quite remarkable. Secondly, they found that not only do you have to have money to go to funerals, but very often if people are gathered in a temple or a church, where if they're going to speak, they have to walk up to a microphone and stand up in front of a big group. They found that people who are otherwise shy and reluctant to speak spoke. They were in their living room and they sat there and they were comfortable and they said what they had to say. So I would hope that we'd have a hybrid, some form of hybrid on the other side of this, where all of those things can happen as well.
Yeah.
Yeah, I can tell you that my congregation on Martha's Vineyard is asking, when we're able to regather as church in our case, will we still be able to live stream our services? Because we really like being able to be part of it, even when we're not there. We have about 5 more minutes of questions. So if you have a question for Mary or Ali or Storm Swain, or Peter for that matter, here's your chance. But if you don't have any, my question for Mary and then Ali, given the time, is what is the one thing that you would suggest that will promote mental health over the next 2 years?
I'll go after Mary.
Thank you.
I guess what I would want to address your question a little bit this way, Stephen, to say what I'm suggesting to promote mental health right now with the clients that I see. And it's very, very basic. Get out of the apartment. Get into a park. Start walking, start biking, continue walking. Pay attention to nutrition. Be vigilant about uses of alcohol and other substances. Pay attention to sleep as the foundation of physical and mental health. I mean, this is so basic, it hardly bears repeating, but it bears repeating because that's what I think. If we believe, as I do, body, mind, and spirit are one, start with the body.
Thank you. And before we get back to you, Ali, I saw Fred raise your hand.
Yeah, I just had one comment. Much of what this webinar is about has been, in some way, educating faith-based leaders to refer to mental health providers. But in some ways, are we doing a significant injustice to the amount of grief work that chaplains and local faith-based leaders can provide their congregants? Because there is clearly a role for clergy of various types as a part of dealing with the healing as a result of whether there's complicated grief or non-complicated grief. So I think it's important that we lift up in as much as we talk about the importance of mental health, we also need to lift up those of us that have spent a lifetime practicing compassionate, non-anxious presence, who are not licensed mental health providers.
Sure. Thank you. Dr. Swain, did you want to respond?
Sure. I think that's a really important point. And at the beginning of the toolkit, there's just an affirmation that keeping our congregations and houses of worship going and caring for others in the midst of this and drawing on all our normal resources is a really helpful thing. I think what we're wanting to highlight is when we get to the edges of our competence or confidence, or when somebody is presenting a mental health challenge in ways that is beyond our training or experience or resources, or sometimes simply time, there are resources available to refer. But of course, I think most of us are dealing with, caring for others with increased amounts of stress, and as far as I can see and hear from my colleagues, doing it incredibly well. And then there are some others of us that are dying because we are hit by the virus, or have, thinking about, I have a mounting list of dead in my community, and I have pressures to want to gather or do something now or wait, or, so I think the stresses around this are really huge. And yet our ordinary, non-anxious presence, bearing the pain of suffering in the midst of what is going on, and finding new ways to care across distance, and yet drawing on those same abilities to be alongside, to empathize, to be present to others, is the bread and butter of this pandemic for so many of us.
Great. Thank you. Thank you both. Ali, you get the last word, and then back over to Peter.
Thank you. I mean, this is a very important question for faith and religious leaders and for us all. As a mental health professional, there are certain things beyond my limitation, my capacity, and I want to make sure that people are talking to their spiritual or religious leaders, especially when it comes to issue of grief, until it becomes more of a clinical that needs to be dealt with. So back to the question that you asked earlier, when we talk about what is the important thing for us to do at this point to maintain our health for the next 2 years, I would say even beyond 2 years, for lifetime, it's self-care. We have to know how to take care of ourselves so we'll be able to take care of others. We have to learn how to use positive coping skills to get us over the crisis and learn how to balance that physical and mental health. Often, and I have to say, from experience, that I find first responders and faith leaders are the ones who are not really good at taking care of themselves. And that's why I always hear about this compassion fatigue, this burnout among clergies. So for faith leaders, it's very important that you learn how to take care of yourself so you'll be able to take care of others. Look for ways that can minimize your anxiety or stress. This is a new norm for us. Something, it worked in the past, it may not work well for us right now. So we have to come up with things and avoid the negative coping skills, mainly the negative coping skills. And you see this in a lot of news media now discussing about how the rate of alcohol and sales have skyrocketed. This is not a good way to take care of yourself by numbing your feeling using negative coping skills. Take care of your health, take care of your spiritual health and your mental health. Use positive coping skills. Self-care, self-care, self-care.
Thank you. Thank you, Ali. Thank you, Mary. Thank you, Storm. Peter, over to you.
Thank you to all of our speakers. This was really, I feel like it's sort of the beginning of a conversation that needs to continue. I started my career as a campus chaplain. At the same time, I was a volunteer chaplain to an ambulance company. This would have been in the late 80s. And I think something that I've noticed over the years that particularly training disaster chaplains and the conversations that come after horrible things happen is that I fear families and sometimes communities get stuck and don't give themselves permission to grieve properly because they're waiting for some aesthetic scenario that they think is the right time. And I don't think the right time is going to come for COVID. And I hope that we're giving our congregations and our houses of worship and our greater faith communities permission to name something as a time to grieve and not fall into the old adage of perfect is the enemy of good. It comes out on social media. It's come out in some of our conversations that people are waiting. They're waiting for houses of worship to reopen, waiting till you can have large gatherings, waiting until you can meet in person as a family. And that is not a healthy way to process our grief, which is complicated by the fact that this is not normal grief. This is this kind of collective global experience of isolation and death at a scale that we haven't seen in a century. At the same time, we're face to face with a society that is in pain because of political conflict, and a society that is once again being asked to reconcile our history of racism and racial oppression and police brutality. Talk about complicated. I mean, none of that has been easy for us to deal with as a faith sector, and we're supposed to be helping people lead and understand these things along with our mental health colleagues. So I'm simply concerned. I just want to name that for how we as a faith sector talk about grief and give people permission to grieve and even say we must grieve now because we can't wait. We simply can't wait for something that may not come for several months and may do damage, something that Ali teaches when he teaches mental health first aid instructors is that the average American doesn't seek clinical help for 10 years once they start showing signs or symptoms of mental health distress. If we think about our role as caregivers in faith communities, how do we give people permission and even insist and instruct people to enter into grieving rituals and to consider the signs and symptoms of distress that they have because of these other factors, and to seek out pastoral counseling or clinical help now, not when you can meet face to face, not when you can have large funerals, not when you can gather as an entire congregation again, because the damage is being done during that period of time. So I will leave you with that thought and simply remind you that we will be sending out an evaluation, and we hope that you will complete that evaluation and share your insights with us and with Thrive NYC so that the Interfaith Center and NYTIS can continue the conversation about how we build a more resilient faith sector. That is the goal of our program here at NYTIS that Helena Duran runs. We are trying to make sure that as the city faces increasing threats and hazards, that our faith leaders and the faith communities of our city are resilient in the face of these crises, and that we are capable of helping people navigate them both emotionally and spiritually. So thank you for joining us. Please complete the evaluation and be well.
Thank you.